Position the patient supine in the bed with the head slightly elevated. Bedside ultrasound should be used to find an appropriate location that contains acidic fluid but is devoid of loops of bowel or solid organs. Mark the site of needle insertion with a skin marking pen.
This illustration shows the preferred positions for the paracentesis procedure. The key concept here is to avoid the epigastric vessels during the puncture attempt. Note the location of the epigastric vessels just lateral to midline on the abdominal wall. So we want to use that 3 MHz probe, and we can place the probe as shown in positions 1 and 2 in the traditional lateral gutter approaches for the paracentesis procedure. This would be above the anterior superior iliac crest. And we can look for fluid within the lateral gutters and plan for a puncture attempt in either of these positions. We can also place the probe in probe position 3 as shown in the midline Linea Alba position. We'd want to place the probe below the umbilicus in the midline in the relatively avascular midline Linea Alba position. Just remember to decompress the bladder prior to a midline Linea Alba puncture, as we don't want to perforate through that bladder. Now we can also use the 10 MHz higher frequency probe to get a better look at the abdominal wall in relation to the bowel and the ascites fluid prior to our puncture attempt. In fact, this will give us a more detailed look into the abdominal cavity to better plan our approach for the paracentesis procedure. This video clip shows a small amount of ascites as taken with a 3 MHz probe, and we can see here a small amount of ascites is denoted by that dark or anechoic fluid collection, and we can see the intestine with anchoring mesentery swaying back and forth within the ascites as the patient breathes. And this is known as gut sliding, and it makes the intestine look almost like palm trees swaying back and forth within a breeze. So from this location, it might be unsafe to perform a paracentesis, as it could be difficult to get a needle in between the areas of intestine without puncturing through an area of intestine or mesentery. This video shows a moderate amount of ascites, again taken with a 3 MHz probe, and we note the intestine with anchoring mesentery sliding back and forth as the patient breathes, and we see a large collection of ascites, that dark or anechoic fluid collection, anterior to the intestine. So this might be a good location to perform a paracentesis, as we could place the needle safely into that ascites without going through into the intestine or anchoring mesentery. This video clip shows a larger amount of ascites, and we still see the intestine with anchoring mesentery swaying back and forth as the patient breathes, but notice it's very deep in this location, and there's a large amount of ascites anterior to the intestine and the anchoring mesentery. So we could safely perform a paracentesis procedure from this location, and the needle could go pretty deeply into that ascites pocket without any intestinal perforation. This video clip emphasizes the point that using a higher frequency 10 MHz probe on the abdominal wall gives a more detailed exam of the evaluation of the ascites in relation to the intestine. And we see the abdominal wall anteriorly, and we can see the bowel floating within the ascites. Here we can actually mark down and measure the safety zone in which a needle could safely go through the abdominal wall into the ascites without hitting bowel. Note here, the safety zone is approximately 2 centimeters as marked out with a centimeter dot towards the right of the image. Another benefit of using the higher frequency probe prior to a paracentesis procedure is to investigate the depth of the abdominal wall, as a thick abdominal wall can frustrate attempts at a paracentesis procedure. Here we see the depth of the abdominal wall, which measures 2.5 centimeters anteriorly, and we can see the line, which is the peritoneal lining there, just deep to the abdominal wall. Note the presence here of ascites, the dark fluid collection, just deep to the peritoneal lining, and we can see the gut sliding or bowel moving back and forth deep within the ascites. Note the 2 centimeter safety zone for placement of the needle into the ascites fluid, but note here we'd need to use a longer needle, a needle longer than 2.5 centimeters, just to get through the abdominal wall to get fluid from the abdominal cavity. In this video clip, we've moved the probe slightly lateral from the last position in the same patient. Again, we note the deep abdominal wall at 2.5 centimeters, denoting that a longer needle will be needed to get the ascites fluid. But here we see a large collection of ascites, and note here the absence of gut sliding, denoting a larger pocket of ascites and a more favorable position for the paracentesis procedure. So this is actually the position in which we perform the paracentesis using a longer lumbar puncture needle, and we're safely able to get a paracentesis done and get the ascites fluid out for evaluation in the lab. Now, some of the surface anatomy that we can palpate includes the iliac crest, and note here we're about 4 to 5 centimeters above the iliac crest there. We also want to avoid those all-important epigastric vessels, which we can see medial to the puncture point from the lateral paracentesis approach. Also recall that bladder can be a problem if it's really overfilled, so it's important to have the patient void prior to a puncture attempt during paracentesis. Using ultrasound guidance, we can map out the best position on the abdominal wall for the paracentesis approach and go either right or left side depending on the maximal pocket of ascites present. We also want to ascertain the relative locations of the liver and spleen so as to avoid iatrogenic injury to a solid organ. And as we emphasized earlier in the video clips, we want to look for that intestine with anchoring mesentery so as to avoid intestinal puncture during the procedure. While the lateral gutter approach to paracentesis is commonly emphasized during medical training, the midline linea alba position can be a great location for a paracentesis procedure. Note here, the probe is placed along the midline linea alba with a marker dot towards the patient's head, and we see it placed along the midline just inferior to the umbilicus. Here we'll further investigate the midline linea alba position for the paracentesis procedure. Note the high-frequency probe placed along the midline linea alba, and we're coming with a cap needle at a 45-degree angle underneath the probe, looking for the ring-down artifact onto a suitable pocket of ascites. Here's a different viewpoint from the same midline linea alba position. Again, we're placing that probe along the midline, and this would be about the appropriate position for the paracentesis procedure. And here we just place the needle right there, directly inferior to the umbilicus. And I'll indicate that with a black star. Note here, we'll be coming through the relatively avascular midline linea alba. But recall that it's very, very important from this position to not puncture through the bladder, and we can see the relative location of the bladder in relation to the puncture point. So we must have the patient void or place a Foley catheter prior to attempting a paracentesis from the midline linea alba position. Note again here the location of the epigastric vessels lateral to the midline linea alba, and we can see here that a puncture point from the midline linea alba approach would safely avoid puncture through the epigastric vessels and avoid any unnecessary bleeding through the abdominal wall. Here's a video clip from the midline linea alba taken with a 3 MHz probe. I have the probe oriented towards the patient's head, so the superior aspect is towards the left and inferior is towards the right. Note here we see the bowels superiorly moving up and down within the ascites fluid, which we see in the middle of the image here, and note the bladder relatively large towards the inferior aspect of the image here. Now we can see that this would be a pocket amenable to paracentesis, but recall again, to increase the safety of the procedure from the midline linea alba approach, we'd want to drain the bladder prior to a puncture attempt. Here's a video clip taken from the same patient after having him completely void, and note now we have the decompressed bladder, making the ascites pocket much larger and more amenable to a paracentesis puncture from that midline linea alba technique. And we can see here now the pocket of ascites as denoted by the darker anechoic fluid collection between the bowel superior and the decompressed bladder inferiorly.
The paracentesis needle should not pass through sites of cutaneous infection, visibly engorged subcutaneous veins, surgical scars, or abdominal wall hematomas. Prepare the site with an antiseptic solution and then apply a sterile drape. Using a 22 or 25 gauge needle, anesthetize the superficial skin with a wheel of local anesthetic such as lidocaine. Continue to anesthetize the deeper tissues in the anticipated tract of the paracentesis catheter, intermittently pulling back on the syringe every 2 to 3 millimeters. Once peritoneal fluid begins to fill the syringe, inject additional anesthetic to anesthetize the highly sensitive parietal peritoneum. A total of 5 to 10 milliliters of lidocaine is generally used. In this video, we will demonstrate an angular entry technique, in which the cutaneous site of insertion does not directly overlie the site of penetration into the peritoneal cavity. Alternatively, a Z-tract technique may be used. In this method, the cutaneous tissues are pulled 2 centimeters caudad prior to needle insertion and advancement through the peritoneum. When the catheter is withdrawn at the end of the procedure, the cutaneous entry site will retract to its original position. Both techniques ensure that the cutaneous and peritoneal insertion sites do not directly overlie each other, theoretically minimizing the risk of an acidic fluid leak following the procedure. Intermittently pull back on the plunger as you continue to advance the needle through the subcutaneous tissue. You may feel a sudden loss of resistance when the needle pierces the peritoneum. Immediately stop advancement once the acidic fluid begins to fill the syringe. Next, guide the plastic catheter over the needle and into the peritoneal cavity, and then remove the needle. If a diagnostic sample is required, attach a large syringe to the catheter and aspirate 30 to 60 milliliters of fluid for analysis. For therapeutic large volume paracentesis, attach the high-pressure tubing to the end of the catheter and then to an evacuated container. Blood culture bottles should be inoculated at the bedside using aseptic technique if spontaneous bacterial peritonitis or other infection is a diagnostic concern.